One of the many notable things about the work of the Age-Friendly Health Systems Initiative is the relevance and resilience of the core interventions that are called the four M's, focusing on what matters: mobility, mentation, and medication. When COVID-19 began to spread in the US in March, there was legitimate worry about the vulnerability of especially elderly individuals, and nursing home outbreaks began to underscore this. The tragic loss of life tied to these settings has been profound, and it's part of a story we're still grappling with. Back in March, there was also concern that emerging best practices for engaging with all older patients, with or without infection, and across the healthcare system, were going to be shoved aside. So, just the opposite happened in some respects in some places, including healthcare practices, and some hospitals engaged with IHI and its partners to improve how the healthcare system supports and treats older patients. So that's where those four M's come in again. They turn out to act as directional indicators or wayfinders, if you will, under some extraordinary circumstances. So, precisely how is worth highlighting as we continue to draw lessons and possibilities from the COVID-19 pandemic. And that's our focus on this show today. We welcome as panelists Dr. Mary Tanetta. She's a professor of medicine and public health and chief of geriatrics at Yale School of Medicine and Yale New Haven Hospital. We're awaiting the arrival of Deborah Conley. She's the service executive and gerontological clinical nurse specialist at Methodist Hospital in Omaha, Nebraska. Dr. Mark Supiano holds an endowed chair in medicine and is professor and chief of the geriatrics division in the University of Utah School of Medicine. And we do welcome back IHI's Derek Feely and Don Berwick. They are our regular expert panelists on these virtual learning hours. So hello to all the panelists. Hello to everyone joining us. As usual, we're going to hear from our panel for about 30 minutes, and then we'll turn to Q&A and discussion. You are free to chat in your questions, your comments, and ideas throughout the hour together. We'll address your thoughts after we've heard from all our panelists. And so let's get underway. Don Berwick, remind everyone what the Age-Friendly Health Systems Initiative is about and why it's so important to our continuing discussions about the pandemic. Thanks, Don.
Thank you, Madge. Can you hear me okay?
Yep.
Yeah, two streams, two rivers of IHI work are coming together in this show in a really exciting way. The Age-Friendly Healthcare Project was the brainchild of Terry Fulmer, Dr. Terry Fulmer, who is the president of the John A. Hartford Foundation and a former member of the IHI board. Terry recognized that a lot was known about how to make healthcare better for elders at a time when we have more and more elders and a lot of vulnerability. And she proposed quite a massive agenda, a project with IHI that would bring the best of science to people that deliver care to and care for elders. The age-friendly framework that you can see on this slide came from the work of at least a dozen scientists, including Mary Tanetti, who have been supported by or convened by the John A. Hartford Foundation and later IHI to come together with a framework. This stream has been underway for now 3 years. It's one of the most exciting projects I've seen. Hundreds of healthcare organizations, not just in the US, but abroad, are adopting the framework, testing it out in a collaborative model. IHI is hosting with the leadership of Kate Armate and Leslie Pelton and Alice Bonner and other IHI people. Along comes COVID, proof of case. The special vulnerabilities and circumstances of elders in all four M's and beyond could not be more relevant to the COVID epidemic as we watch the vulnerability of elders, disruption of families, the mental health and physical health burdens, what matters, the appropriate use of medications, mentation, and orientation, especially in conditions of isolation, as also mobility. These echo strongly in the COVID environment. So here we have, like we were getting ready with the age-friendly process to deal with a very, very important theme in the COVID world. And now we have experts in this panel to join us and help guide us in understanding that connection. So thanks for all of the panelists for joining us, and Madge, back to you.
All right. Thank you, Don. So, Mary Tinetti, you've been an extremely important faculty lead expert in this initiative. How would you characterize the impact the pandemic has had on the Age Friendly Health Systems initiative? And I'm also curious, maybe what you would say the other way around. How has the initiative impacted maybe the pandemic? Thank you very much.
Yeah, thank you, Madge, and thank you for having me to be able to talk with you today. Let me start by saying I've been incredibly honored to be part of the age-friendly health system that's supported by IHI and the John A. Hartford Foundation. And I'll tell you, my own evidence of the success of the spread is that I'm hearing from people that don't know that I've been part of it since the beginning. Have you heard about this age-friendly health system in the 4Ms? It's really evidence that it's spreading. And as those of you know, I was a little bit skeptical at the first that this seemed awfully complicated, but success is happening. Let me just, if it's okay, Madge, I just want to talk about, so personally, what's happening very, very briefly at Yale New Haven, Yale New Haven Hospital, where I provide my care, because it firsthand has showed me the relationship between the age-friendly health system and in the 4Ms. Yale New Haven Hospital is a 1,500 bed hospital in the smack dab in the middle of the state of Connecticut. We are part of a 6 hospital system that begins in Greenwich, Connecticut, a suburb of New York City, which has impacted us greatly over the last several months, to the border of Rhode Island. New Haven, in which we live, is one of the most socioeconomically and ethnically and racially diverse cities in the United States. So we have seen it in its effect firsthand. We've had literally over 3,000 patients now in our hospital, many, many more out in the community with COVID, many in respirators and in the ICU. Here, as everywhere, it's affected older people more than younger people, and African American and Latinos more than whites. And we have seen the devastation of nursing homes. But to put it into perspective, is the vast majority of older adults who get COVID do actually reasonably well. We had a high percentage of asymptomatic people here, very much like younger people. Those who are hospitalized, many of them never need to go to intensive care, and many of them are discharged. The long-term consequences really remain unknown. But we are at the bottom of the curve. Hopefully we'll stay there. On our weekly meetings that we have now, we have, for the very, very first time yesterday, there was no new admissions for COVID since I think middle of March. Obviously, like every place else, people are opening up and getting out, and we're in the midst of very active protests here. We're all keeping our fingers crossed. Everybody's exhausted, and hopefully the next wave won't come, but we're prepared if it does. So that's just my context of where I live in the COVID world. We all have our place in the COVID world today. That's changed everything. So you asked me about how COVID has affected age-friendly health systems and vice versa. So let me just touch on that for a couple of minutes. First and foremost, it's obvious that COVID is particularly affected older adults, and I won't go into any more details about that because we all know it, except for to say is that although it has been devastating, older adults are getting through this as well as older adults, and I will come back a little bit more to that later. You're going to be hearing some specifics about how the age-friendly health system activities have changed as a result of COVID from my colleagues at Age-Friendly Health System. So I really want to talk more conceptually about how the 4Ms can help us understand the effects of COVID on older adults through this pandemic, and really more importantly, focus what I think are how the 4Ms can really help guide health systems, get us through not only COVID, but beyond. As for the effect of the virus on older adults, I'm going to simply state that when you consider its many manifestations, it affects every single one of the M's of what matters, medications, mentation, and mobility. And we can understand the effects of COVID on older adults through the 4M framework. We had not anticipated COVID when we came up with that framework, but I think it really helps us understand its effects. But more importantly, I think it's going to help us understand how to respond to it and guide us as we do respond. And I want to start with an example from the ambulatory setting. Those of us who provide care in clinical settings know that overnight, literally overnight, we went from the typical face-to-face contact between clinicians and our patients and their caregivers. Overnight, we went to telemedicine, trying to deal with the video conferencing, which I don't know about other places, but here in New Haven still has a lot to be desired in terms of its technology in 2020. Sad to say, hopefully that will be a positive outcome of COVID. But we weren't prepared to have those kind of encounters. We didn't know how to frame them. We didn't know how to have them. We were all uncomfortable with them. And one of the groups that have been involved with the age-friendly health system, but also involved with me on John A. Hartford initiative that we are doing called Patient Priorities Care, stepped into the fray and identified a framework for having these conversations by phone and by video, framed within the 4Ms, beginning with what matters most, tips and scripts for addressing medications, addressing mobility, addressing mentation, all within the framework of how COVID was affecting their life, affecting those 4Ms and the rest of their health care. And it's a beautiful conversation guide. I think it's called the COVID-19, I can't remember exact name. It's the Patient Priorities Care in an Age-Friendly Health System telehealth guide for COVID-19 communications. And it is on the IHI COVID resources. So I suggested you all go out through it. But it was an amazing, innovative response very quickly to framing COVID, responding to a problem we didn't know on Monday existed that was countrywide on Tuesday. So I want to talk a little bit about the relevance of the 4Ms in understanding and management COVID. Beginning with what I personally think is the core of the age-friendly health system, should be the core of health systems for all ages and everybody, the what matters. And I'll say what matters has affected COVID in two ways. The immediate response. It became instantly clear as we all recognized the devastating potential effects of COVID, as well as the treatment of COVID on everybody, but particularly older adults. The prolonged, uncomfortable treatments, particularly if one have to be in the intensive care unit or having drugs that we didn't know how they were going to respond. How do we have those difficult conversations when we had so much uncertainty and we didn't know if we were going to have the resources? I spent many evenings on Zoom with a large group of interdisciplinary people trying to talk about what are we going to do when we run out of respirators, when we run out of medications. And as a result of that, we did a group of clinicians, primarily palliative care and geriatrics, but other people as well, put together conversation guides that how do you have on the phone or by video with people you've never met before, have that conversation of what do you want for your healthcare, what matters most to you, and what might happen to you, and what can we do to help make the decisions of what might happen. And again, overnight came up with some beautiful conversation guides to address the difficulty of what matters in that particular moment that nobody had anticipated in January or February, that became center stage in March. And that's called the COVID-19 Goals of Care Scripts for Older Adults. There's ones for a nursing home, ambulatory, and hospital. And again, if that's not part of the IHI resources, I will send it your way. I've had more than one clinician come up to me and say, I've been doing this wrong all the time. I never knew. I've learned a tremendous amount. So this is not just happening here. People have developed these resources and doing this other places. I hope it changes the conversation forever. I think it's going to hopefully be one of the positive responses of COVID. But it also, I think, what matters really is important as we go through the opening phase as well. here in Connecticut, I'm hearing across the country, as we're opening up, let's get out there, let's get back to work, let's start doing things, doing it safely. But if you're old and if you're ill, you stay home. You continue social distancing. Like we know what matters most to all older adults. And now we're a phase of this where it was really important that everybody stayed home and everybody social distance and everybody do that. But now as we're opening up, we're learning more and more the adverse effects of that social distancing on their cognitive, social, and physical health. And now is the time. People do vary. We know that people vary when they're faced with that trade-off between being at risk for COVID versus being at risk for the adverse effects of not getting out and living their life. It's not up for the state. It's not up for me as a geriatrician. This is important. What matters really needs to inform what happens as we open up. And that's something I think perhaps IHI can help with. So I think it's the continued social isolation needs to be measured against that. So I hope that really does happen.
Hey,
So
Mary.
yes,
Whoops. Mary and I had this friendly agreement
yes,
that if I interrupted, nobody would take it personally.
I do not take it personally.
No, right. You're saying so many important things. I can't even, I don't know what's the matter with me, but I'm going to just sort of say pause right there. I know we've got, this is the richness of this material, everyone, in terms of mobility, medication, all the areas. But I'm going to just say a pause there so we can hear from our two sites around the country in Nebraska and Utah. And I promise everyone that we'll continue to sort of pull on some of Mary's ideas and thinking, which is so important through this process right now. So thank you, Mary. And what I'd like to do now is turn to Deborah Conley. We spoke ahead of the program, Deborah, and I learned that at the end of February, you organized a major retreat on age-friendly health systems, mapping out with others a year's worth of plans for the Methodist health system. And then 1 week later, March 5th, you were part of your system's incident command because of COVID-19. So tell us this story and how it has influenced what's happened with AgeFriendly. Welcome, Deborah.
This is a delight for Methodist Health System to be a part of the Age-Friendly Journey and to be able to share with the IHI audience. So you can see that we have 4 hospitals. I happen to work at Methodist Hospital, and then Jenny Edmondson is across the river. We have 20 ambulatory care clinics, and those are throughout the whole process of Age-Friendly. And we have a hospital in Fremont, Nebraska called Methodist Fremont, and then we have a women's hospital. So that kind of gives you an overview because there's representation on our geriatrics operations team from all of these entities. Next slide, please. This is the last slide for the rest of the speakers because we really weren't going to do slides, but I wanted to show you our journey. It really is a journey and not a destination. So in 2018, if you look at the bottom, our strategic planning throughout our health system identified that we needed to develop a unique system and a solution-wide, develop a unique process for a system-wide solution to the care of older adults. And what we determined was that we would use the age-friendly health system as part of that. So throughout all of 2018, we continued to just have discussions, get leadership on board, network, and get our process planned, or at least thought about planned. So in 2019, and this is one of the things Leslie and I always talk about, is our geriatrics operations team. I always say this committee's got it because they are the ones that do the majority of the work. So during that time, we then participated. We got our GOT team together. Then we looked at, oh my goodness, are we going to start in the clinic or are we going to start in the hospital? Well, we decided that we would start in both of them. Despite how difficult that may have sounded then, we were able to identify some pilots at Methodist Hospital, which is our acute care for elders unit, has 32 beds, and their focus is the 4M's interdisciplinary rounds. And then we identified 2 primary care clinics that really was focusing on the Medicare annual wellness visits using the 4M's framework. In February, we enrolled in the IHI webinars, and then we were a part of the Second Action community. And I just can't stress enough to everyone the importance of being on this journey and being a part of the IHI age-friendly communities, action communities. They really guide you and provide you guidance throughout your work. We wouldn't have thought about the Medicare annual wellness visits, but that is the best practice through IHI and the John A. Hartford age-friendly work. So as we moved on, then we identified, as it says there in March, we identified and defined the 4M's. So we were asked by IHI to identify what those look like so that we could then really track and monitor that process. Then from there, we did that, and then we put together what are called the 4M subcommittees. So we have a subcommittee for mentation, what matters, mobility, and medication. It is in the subcommittees that all of the work gets done. So that's those subcommittees really look at identifying issues, identifying tools, looking at processes, really looking at that whole implementation science of the best practices. So within that, we started working in the 2 pilots, both the clinic as well as the ACE unit. And then in September, we were identified those areas as committed to care excellence for older adults by IHI, which means we were able to submit data from those sites showing how many older adults have participated in age-friendly and have received the 4M's. We were delighted that both our clinics were like double the amount, so almost 2,300 patients from April to September. And at the ACE unit, almost 900 patients received the 4M. Implementation continued and developed throughout the rest of 2019. And then starting in January of 2020, we continued to refine the processes. And remember, these are only on the pilot unit. They're not everywhere yet. But as Madge said, February, then on March 5th, we had a retreat in February. We had about 45 people there from across the health system. Our 4M's committees, as well as our GOT committee, has both ambulatory and hospital representation. So COVID-19 arrived, and our health system was the first hospital with a patient. So as we totally know, all committees were put on hold. Many of our age-friendly leaders and committee members were in COVID, incident command, and other committees. But we know clinical care continues, along with COVID-19 planning and readiness. So in the hospital, we had to really focus on adapting and modifying the 4M's rounds on the ACE unit because the interdisciplinary team couldn't get together, PPE, social distancing, visitors and families were in here. So our geriatric nurse practitioner, Mary Kay, went around and she continued with the rounds and then communicated with the staff nurse, the patient, as well as the other team members gave input from that perspective. Then March 1st, so if you think about March 5th is when COVID occurred here in Nebraska. On March 1st, we had just developed, we had just implemented the new desk screening at 3 of our hospitals. So that continued, but we really had less focus on hardwiring that, making sure that nurses were using the tool correctly, but we're starting that process back again. We use what's called the My Story tool. Again, that is something that usually families and patients fill out. And currently we don't have visitors except for some exceptions. So that made it more difficult to use the My Story tool. But again, that still continues when necessary if the staff nurse and and other disciplinary team members can work with the patient on that. We had help volunteers that were no longer here anymore. Can't wait to hear from Mark about his program, but we really miss them. We would have loved to have done something virtual. We actually talked about that in April, but we didn't have the bandwidth to do that. So we also implemented what's called a communication liaison at Methodist Hospital. And in particular, that liaison helped patients, families, and staff set up Zoom meetings, WebEx, telehealth, FaceTime, all those things that everybody's been using. So let me tell you what's happened in the clinic. Annual Medicare wellness visits continued, but they were very shortened, but they used the 4M still. They had a drive-by lab, they started telehealth, and within our clinics, we had not done telehealth. So that was a huge undertaking, and both providers, families, and staff learning how to use that. The other is that they really continued to, or they started to partner with palliative care, like Mary said. They're really looking at starting those crucial conversations about advanced care planning. With the high-risk patients, our health coaches, our nurses called those patients, checked in with them, found out how they were doing, did they have food, what about their medications, what kind of social support did they have, and if there wasn't an advanced directive or advanced care planning discussion started, they really just kind of planted the seed where then providers could follow up. That was a big part of the processes in terms of where we are today. So we know throughout this whole process of the GOT committee, IT is an integral part. And I just really want to shout out to Marie Kozel, our head, if you will, of our IT clinical informatics that's worked with us on all 4 subcommittees in the GOT team. So they continued their work behind the scenes. And I'm delighted to share that this week we were able to view a draft of our 4M's tab in Cerner. It will be where all the information on the 4M's will auto-populate. So it's in a rough draft, but we'll be able to see ambulatory and clinic and hospital by clicking back and forth with just one click. So we can see what each other are communicating. And for example, what about advanced care planning? What about their medications? What about deprescribing? And then they also have been developing behind the scenes a 65+ check-in. And so whenever a patient comes to one of our clinics, whether it's primary care or a specialty clinic who's 65 or older, they will have an abbreviated 4M check-in. It won't be like the full 4Ms with the annual Medicare wellness visits, but we're delighted about that. That's just in the kind of finalizing stages. They've got a couple more things to do on that. Other IT work has continued in terms of developing. The team working on mentation is developing, kind of revising some updated dementia and delirium care plans, as well as the mobility team working on a mobility care plan. We know dashboards need to track our outcomes. So there are really many things to reconsider. So if you look at our timeline here, COVID arrived, June to December, we're meeting again. We started meeting again this month, working on our action plans. And really the whole purpose of these meetings this year is going to be focusing on spread to our other 3 hospitals per se and our clinic. As Mary really mentioned, I just want to say one of the big things for COVID for us is how are we going to reframe what matters? Because while patients, older adults have been in the hospital, they haven't had their families, maybe then with all the, PPE and the goggles and all those things, it's really important, the communication, the impaired sensory deficit. So what we want to really find out, and we don't know the answer to this yet, is what is really important in light of COVID to older adults when they come into the hospital. So in closing, I would just like to share a famous quote that you've all heard by Henry Ford on teamwork. It really makes me think about the Methodist Journey and the team that we have working on AgeFriendly. Coming together is a beginning, keeping together is progress, and working together is success. Really, like I said earlier, it's a journey, not a destination. We want to be able to, next May, Older Americans Month, celebrate that all of our clinics that we want to be age-friendly and our hospitals will become age-friendly and recognized by IHI. So that's our journey. I look forward to some questions. And again, Leslie and Madge, thank you for inviting me to participate. And I can't believe I did it in my time frame.
Thank you so much, Deborah. A lot going on there. And yes, feel free to start popping in your questions. We will get to them in a few minutes. First, so be patient all. We're just going to slowly go over the half hour, but that's okay. We'll get in your questions. I'd like to now turn to Dr. Mark Supiano from the University of Utah Health System and find out kind of how his health system made some adaptations in light of their work also on Age-Friendly. Thank you, Mark.
Well, it's my pleasure, Madge. Thank you so much for including me in this really timely and critically important discussion. I'm going to zero in on one inpatient aspect of our age-friendly health system perspective, but just if you could actually go back one slide, I'll just give a little bit of context first of our location and our health systems. So I'm with the University of Utah Health System, our main hospital, the only academic tertiary care hospital in Utah in the Intermountain West, is located in Salt Lake City. If you're not used to looking at the Wasatch Front from this perspective, this is looking east, so looking east toward the Salt Lake Valley. We have 12 community clinics spread across the valley as part of our system. I am happy to tell you more details about our journey, as Deborah just did with the Age-Friendly Health System. We were part of the first wave of the action communities and got on board very early on, thanks to a great deal of support from Terry Fulmer and the team from IHI. So next slide, please. What I'm going to focus in on is an inpatient program that we have actually had at the University of Utah now for a decade. As Mary mentioned at the outset, we know that COVID-19 is particularly impacting older people. And just to put this into perspective, with data from Utah, and if you're interested in more specifics about what's happening with COVID in Utah, I'd be happy to address that during the discussion time. But thankfully, only 8% of people who are testing positive for COVID in the state of Utah are requiring hospitalization. However, of that population, half are over the age of 65. So half of those hospitalizations are occurring in people over the age of 65. So with that, having this program in place for the last 10 years, the Hospital Elder Life Program, is what I'm going to zero in on, how we had to adapt it for the COVID situation, and how it is addressing the 4Ms as part of our age-friendly health system care. So just briefly by way of introduction, this will come full circle back to Yale New Haven Hospital, Mary. So when Dr. Sharon Inouye was at Yale, she developed this innovative program, a multi-component intervention to prevent delirium in hospitalized older adults. It is now known as the Hospital Elder Life Program. Next slide, please. So what this program does is really focus and deliver on all 4Ms of the age-friendly health system. In our situation, it's a volunteer-led program. The volunteers deliver interventions to address each of the 4Ms. So starting with mentation, the Elder Life Program is really known. Most people think about it as a delirium prevention program, and first and foremost, that's what it is. And in our institution, for example, our delirium incidence rate decreased from 30% to now continuously being less than 5% in at-risk older adults. So it clearly has an evidence basis to prevent delirium. Beyond that, though, with respect to the mobility M, it also is one of the strongest evidence-based programs to prevent falls in hospitalized older people. From the medication M standpoint, one of the very first things that is done as part of enrolling a patient in Elder Life is to do a biopsy of their med list and eliminate or recommend stopping the deliriogenic drugs that may be there that would precipitate delirium. And then finally, what matters most, the biggest impact that Elder Life has in preventing delirium is that people are more likely to be discharged home and can typically avoid a nursing home stay. And I'll talk about how we're focusing in on this now with the adaptation that we've been forced to make with respect to the COVID situation. So what had happened, the pre-COVID delivery of Elder Life was really uh, entirely dependent upon a well-trained group of very dedicated volunteers, most of whom are pre-professional students from our university, who would be spending an hour a day for each of 3 shifts with patients, delivering protocols that are targeted to each of these objectives that we know will be useful in preventing delirium. They provide frequent orienting. They provide cognitive engagement throughout the day. They provide companionship, particularly during meal times, and promote people's nutrition. Sleep deprivation is a huge issue, and there's a non-pharmacological sleep protocol that they would deliver in the evening. And then finally, they would encourage mobility with active range of motion, and encouraging people to get up out of bed. So when I meet our volunteers during their training sessions, I tell them that they're the medication, they're the pill. And if the pill doesn't get out of the bottle, if they're not there delivering the interventions, the program doesn't work and delirium is not prevented. So next slide. COVID hit a little bit later here, mid-March. It was also introduced with a 4.7 scale earthquake that we had in Salt Lake City on March 18th. So March was a fairly ominous month. But I got a call from our elder life specialist who had just heard from the head of hospital volunteer services that the hospital was no longer allowing volunteers to have any presence in the hospital. And literally our program ground to a halt. And to further compound the situation, and what really troubled me dramatically is that shortly thereafter, the hospital said that in addition to this, we are no longer allowing any visitors with patients in the hospital. So now I knew that we had older people being admitted to the hospital who, even before COVID, were at very high risk for delirium. We could not deliver our program to help prevent it. And to further compound the isolation that these people would be experiencing, they no longer have any exposure to the outside world through their family, friends, or caregivers. So fortunately, I guess, as you've heard, on my ambulatory care side, I had just come from a meeting with our clinic group, and we were trying to get up to speed and ramping virtual visits to deal with the need to deliver care to our outpatient clinic patient population in the setting of not having the ability to bring them into clinic. And it occurred to me, well, if we can do virtual visits in the clinic, why can't we do virtual volunteer visits with patients in our hospital? So that was the light bulb that went on. The action steps then that needed to happen to get to what the picture here the pictures that you're seeing is to bring iPads into patient rooms through which they can connect with our elder life trained volunteers. You're seeing Annie here in her nice red volunteer polo shirt. And deliver virtual help interventions to at-risk older people in our hospital. So I realize we're running a little bit late, so I won't walk through all the action steps, but I first made a call to our advancement team, and we were able to identify a donor who supported ultimately the purchase of 60 iPads and the floor stands that we needed to get this delivered. We had to find a space for the volunteers. We had to adapt the elder life interventions to be delivered virtually. I'll just give one example because I think the mobility M, the medication M, and the mentation M are pretty self-evident. But what matters most in this setting has really been fascinating. What the volunteers have been trained to do to keep people connected is to do their life history and their reminiscing. And that alone, just to make them feel like they're still a person in this very isolated environment now that they're in the hospital. I'll just give two patient stories. One was one of our first people, and we're doing this in the medical intensive care unit. He's a Spanish-only speaking person, and as you may know, Hispanics are really disproportionately been impacted by COVID-19. So he was in the MICU and had not been able to reach out to his family. So the iPad allowed him to connect with his family outside of the hospital, and we were able to identify one of our volunteers who's Spanish speaking to be able to interact with him throughout the day and make him feel connected. The other patient example was a 98-year-old woman who was admitted to the hospital because she fractured her femur. So even in COVID, there's still things happening to older people like falls and hip fracture, very high risk for delirium. And we were able to connect her with an elder life volunteer, and perhaps more importantly, connect her with her daughter. And in talking with her daughter, just hearing how her mother brightened up to be able to communicate with her in a video visit really was heartwarming and really the goal of what we wanted to do. So I'm happy to, I know we're running over time. I'm going to stop here. Just the last slide. I want people to be aware that the Hospital Elder Life program is now being disseminated actively with a partnership with the American Geriatric Society, also supported and with great support from the John A. Hartford Foundation. Thank you, Terry, and others. So this is the website for the new AGS Co-Care Help program, and I would encourage you to check this out. And if you're interested in learning more about elder life, there's a lot of information there. And likewise, I'd be happy to tell you more about that. So let me stop there, but I'd be delighted to answer any questions.
Thank you, Mark. Really important story you're sharing. And Don Berwick, among others, kind of weighed in about that, and hoping as we move forward that we'll learn more specifics from what you've been able to do, not only at maybe the height of a crisis, but important learning along the way. Okay, you've all been fabulous, very patient. We did go over a bit in our timing and our estimates. I would feel free to make comments, ask questions. I think what I'm going to just do very quickly, because I promised, I'd like to go back to Mary Tinetti for just a minute. Mary, now we've got two systems, and that perhaps are somewhat emblematic of what's possible in these realms. And I think it certainly can offer some inspiration about having a platform upon which to build. What are some of your, maybe some quick thoughts on that? And yeah, there you go.
Okay, thanks. Platforms for, I'm sorry, can you articulate a little bit more?
Yeah, just we've got now two strong examples of kind of how you think through changing circumstances. In this case, of pretty scary set of circumstances and rearrangement of priorities. What might you underscore about that? Whether it's medication, taking on the mentation issue. We haven't talked so much about mobility, but certainly what matters.
Yeah, so I think that the bottom line that I've seen here is that we have been able to, the devastation has been terrible, but the opportunities to address problems that we've been trying to address for decades happen literally overnight. If there's nothing else, that's the take-home message here. We can get things done, and I think what we saw, the adaptation that happened in Nebraska, how to use that annual wellness visit most effectively. That's been around for a long time. We've trying to figure out how to do it, how to move things much more virtually. I mean, I think if there's one thing that we have learned here is that we can do an awful lot more with older adults in their home. We haven't talked about the home at all here. Um, with all of the 4Ms, the mobility, the medications. We overnight with the medications, we went to a simplification format based on the work that Nicole Brandt did, who was one of the Age-Friendly Health System people. We literally, I think it's really shown us we can do this, we can get this done. And the Age-Friendly Health System is the health system of the future for our older adults.
Okay, thank you. Derek Feely, you're there. We know you're in Scotland, but you're with us. And what are some of some of your quick thoughts about what you've heard? Thank you.
Well, two great examples, and I think an excellent overview from Mary. Two quick things, Madge, just from me. Firstly, I think one of the big strengths of the age-friendly health system approach is it brings the best of science, the years of research from people like Mary, alongside practical improvement methods. And the synergy that's created by bringing those two things together, I think, is part of what makes possible what Deborah and Mark described. Second, there will be a few things that we learn during this crisis that ought to become just part of how we do our work in the future. And for me, age-friendly health systems needs to be one of them. It shouldn't. This has taught us, I think, our experience of operating in the way that Mark just described and Deborah in the midst of a crisis has taught us that this is something that can work long into the future in a whole range of environments. And so one of the things I think that we need to hold on to when COVID-19 is a thing of the past is working on the 4Ms and creating age-friendly health systems.
Deborah Conley, somebody was interested in asking you what quality metrics you might be using for the 4Ms at Methodist.
Part of the age-friendly initiative and what IHI, they actually share. So on the ACE unit, we're looking at length of stay, readmissions, and delirium rates and prevalence. And then we're looking at the overall HCAHPS related to, would you recommend to family and friends? And what about overall quality of care? So we're just starting within the last 6 months to submit that. That's why right now we're trying to get dashboards together to see if we've made a difference in terms of that. We know that we hope that by the end of the year we have. So I really don't have data to share in terms of that. And then in the ambulatory care setting, it's looking at ED utilization. We're looking at the patient, PRC is who we use for our patient satisfaction. We're looking at the medication questions as well as did the provider listen. Those are the key ones that IHI has asked us to look for. The other one in the clinics are increasing our number of annual Medicare wellness visits. And that has happened like almost 10, 12%, and they want to continue with that.
Okay, thank you. Mary, I wonder if I can ask you just to say a few thoughts, at least in terms of mainstream media coverage. Has been and was a lot of concern about experimental medications, things that were really still in early clinical trial testing. And of course, decisions about aggressive interventions with intubation and use of ventilator. Where do you think, or how has Age-Friendly helped in that? And is that sort of some things that will be taken up more by the initiative, sort of seeing how quickly people can be sort of put into these circumstances, an older person as well as family members.
Yeah, I think I,
Whoops, lost you there. There
okay.
you go.
There you go, yeah.
Yeah.
So I think a couple of different things. Is I think any health, I will just use an example from our health system, that they called upon our age-friendly health system nurses and physicians, the people that have been doing the planning for age-friendly health system, right from the very beginning, in terms of working with nursing homes in our community that are affiliated with our hospital, and they led the efforts, and we had a much lower mortality in our nursing homes than any place else. And I think that is a lasting legacy, that I think for all nursing homes, the relationship between their hospitals and the nursing homes, I think is really key. I think that hopefully this has gotten the message out nationally, and I think we probably have to work with our media colleagues more to push it even more, how important it is for people to have somebody who can speak for them, their healthcare proxy, and to know what matters most to them when they get ill. So it's not a shock when that conversation happens. I think that's what social media and the traditional media can do. I think one thing I think that thread the needle that the media needs to do a little better. There was an awful lot of sort of anti-aging sentiment that was arising. We all had to. Our kids had to stop getting education. We had to lose our jobs so that old people could be protected. That was exactly the wrong framing. And I think I've been a little bit optimistic that things have gotten better along the way. So I think there's things that media can help with and things that they can have not done as well as they could.
Mhm. And how do you see sort of the ability to weigh whether or not I'll just say it, should somebody in a atmosphere in age friendly where you've been trying to focus a little bit more on polypharmacy and deprescribing, along comes, let's say, remdesivir. And there's a lot of consideration. Is that a good thing? Neutral, no harm done, in case it could be helpful? What are your thoughts?
Well, I think the example of, in fact, I was getting into medication, so I should have talked a little quicker before, because medications really is key. And I think what we saw with hydrochloroquine and with remdesivir really shows us how medications and aging really is important in general. Because every medication has potential bad effects, potential good effects. And I think it's a really good example. The question people should ask is this medication likely to help me with what matters most to me in terms of my cognition and my physical function or living as long as possible, or is it going to hurt those things? I think it really shows the importance of the uncertainty with a lot of the medications that older people take. So I think it really is a really good marker for how far we need to go and how we present medications to the public, not just older adults.
Okay. Anyone else on the panel, feel free to weigh in quickly. If you have anything you'd like to say. I mean, there's obviously also a connection between delirium and medication for sure.
Right.
Anything you want to add?
Couple things, actually. Thanks, Madge. So first, to follow up on your comment on what matters and as it relates to the ageism and the potential impacts on resource allocation, I want to call people's attention, and I wasn't facile enough to pull up the reference in JAGS, but hopefully one of your IHI folks who are populating the chat with all these great links can add this. The AGS published a very strong policy statement last month in JAGS. Tim Farrell, who happens to be one of my faculty here at the University of Utah, was the first author. Tim is the co-chair of the AGS Ethics Committee. But the main issue, the take home, is that age alone should never be used as an indicator for determining resource allocation in a time of scarce resources. So that's a very complicated topic, but I wanted to bring this up in the context of your comment about ageism, that there were a lot of discussions as well that we shouldn't be putting nonagenarians or others on ventilators, and clearly age alone should not be that indicator. And the AGS, I'm pleased to say, was very proactive in publishing this very important policy statement to that effect. I wanted to also make a comment. The other part of the health system that we haven't talked about, but has been perhaps most profoundly impacted by COVID is the long-term care setting. And to make the point that the 4Ms apply to long-term care as well. And I know you're looking to get this webinar wrapped up on time. My next meeting is the executive group for our HRSA-funded Geriatric Workforce Enhancement Program, which is focused on delivering 4M care in the long-term care setting. We just were fortunate enough to receive a supplement related to COVID. We're delivering telehealth education focused on the 4Ms to long-term care providers across Utah. So just as another example of how, and to Don's point earlier, age-friendly is here to stay. This needs to be embedded into the fabric of our health system. And certainly in the long-term care setting is another illustration where these principles really need to come to the fore. Finally, you mentioned delirium, and I forgot to make one other important point. Connecting delirium to COVID-19, it may be underappreciated that delirium can be a presenting symptom of COVID infection in older adults. So one of the atypical presentations of COVID in older people. Thank you.
Thank you so much. Wow, I know, so much to learn. We could be here for hours, but we're going to, as you see from the slide here, lots of ways to continue to pursue our panelists, their work, the work of Age-Friendly Health Systems Initiative. Believe it or not, Don Berwick, I do want you to sort of get one last word in here, and I'm going to talk so fast after you're finished to wrap things up. Go ahead, Don.
Just first, a tip of the hat to Mark, Mary, and Deborah. The pace of learning is extraordinary here. As a quality improvement wonk, my question, of course, is how do we take this specific knowledge, these particular ideas that we've heard about, which are so powerful with documented results in local settings, and spread them as fast as we can with due diligence to the integrity of the ideas. I think it's extraordinary with what's going on here. Notice the particular call out on this slide of the 20-minute daily huddles on quality improvement. That's where a lot of specific stuff is being exchanged. So not to overwhelm you all, but if you have the time to join those huddles, they're really extraordinary and a lot of knowledge speeds around. But Mark, Deborah, and Mary, thank you so much for your leadership. It's really inspiring to hear you. Thanks, Madge.
Thank you, Don, and I echo thanks to Mary Tinetti, Deborah Conley, Mark Supiano, Don Berwick, and Derek Feely. Everybody has to be good sports on this show and ride the wave, and you all did a fabulous job. I also want to give a shout out to Leslie Pelton from the initiative for all your help with this program and putting it together. Thank you, audience, for taking the time to participate. And please be on the lookout for the archived edition of today's show that will be posted to IHI.org later today, no later than Monday. And there's a fabulous archive of programs. We've been at this weekly since March 27th. So I hope you'll check out what else we've been talking about. Many of the themes have come through all the shows. We're going to be back next Friday at 10 a.m. Eastern Time with a look at contact tracing and case finding and the strong contribution community health workers can make to this effort. Details soon on that on our website. And boy, fabulous conversation, rapid fire, lots to look at. You can look at all the materials, including the chat, to reflect on what you heard today. Thank you, panel. Thank you, audience. We wish you all the best and good health. For the Institute for Healthcare Improvement, I'm Madge Kaplan.